So, good evening, all the aspirants present here. The topic for today is maternal medicine, and it will be taken by the speaker, the faculty, Dr. Varun Pushkarna, sir. So, over to you. You may start.
Thank you, Sana. So, we had covered most of the topics in the last class, and these are the remaining ones. So, we will be discussing whatever was left in the last class. So, very important topic is RH isoimmunization and the role of immune globulin. So, RH incompatibility, when does it occur? So that happens when a Rh negative mother is carrying an Rh positive fetus. So that means the Rh negative mother, her blood has never seen an Rh antigen. So when the fetus is inside the mother's womb, what happens is at the time of delivery, when the blood of the fetus comes in contact with the blood of mother, that is when the mother's blood gets sensitized to the Rh antigen of the fetus. So this is problematic. Why? Because now the mother will prepare antibodies against that Rh antigen. So the next time, whenever she conceives, the baby, if it is Rh positive, will be killed inside the womb, inside the uterus by the antibodies which can move from the placental circulation. So we all know that the antibodies that are produced at the first exposure are IgM type, but later on they will get converted into IgG type, which are transplacentally movable. So that is the problem. So the fetal red blood cells, when they enter into the maternal circulation, they lead to production of anti-D antibodies. This is very important, which then cross the placenta in subsequent pregnancies. So I'm very categorically saying that it doesn't happen in the first pregnancy, it will happen in the subsequent pregnancies. And they will cause hemolysis of the newborn. Okay. So the prevention, how can you prevent? You can prevent it by giving ready-made immunoglobulin IG. What will it do? There is something known as prozone phenomena. Can anyone tell me what is a prozone phenomena? Can anyone tell me? So the prozone phenomena is that whenever there is an amount of antigen is overwhelmed by the amount of antibody attaching to the antigen, this is the antigen. So what you see here is that there are so many antibodies that they have completely covered the antigen, and the antigen is not available for being exposed to the maternal blood to produce the antibodies. So this is very important that you give immunoglobulin so much that it neutralizes the fetal Rh positive RBCs before the sensitization occurs. So you have to understand what is the timing of the Rh immunoglobulin. Routine antepartum, it is 28 weeks gestation, 300 microgram IM. It will cover 30 ml of fetal whole blood or 15 ml of RBCs. As I am telling you that the concept is based on prozone phenomena. Hence, you have to see that the amount of antibodies that you are giving, they are matched to the blood of the fetus or the RBCs of the fetus. Within 72 hours of delivery of an Rh positive infant, the mother gets another shot of 300 micrograms intramuscular. Potential feto-maternal hemorrhage, that is miscarriage, abortion, ectopic, or amniocentesis, chorionic villus sampling, trauma, all these things, they require 50 micrograms of dose if it is below 12 weeks, or again 300 microgram of dose. So mota mota, you have to remember that the dose of the Rh immunoglobulin is 300 micrograms, if anything after 12 weeks of pregnancy. So what are the key laboratory tests? You send indirect Coombs test, indirect antiglobulin test that detects the maternal antibodies. It's a screening test. Direct Coombs test detects antibodies attached to the fetal or neonatal RBCs. Then there is a KB test or Kleher-Betke test or flow cytometry, which quantifies how much fetal RBC in maternal blood are there to determine the need for any additional. So you remember 300 microgram is the dose that we are to give. But if KBT tells you that it is more than 30 ml of uh, the fetus, the fetal blood, then you have to give more dose. So, if the exposure has already occurred, now sometimes when the pregnancies are unattended, the patients they come directly. So then the immunoglobulin has no role. Then you have to manage the pregnancy as a high risk pregnancy because you don't even know if the patient has had a miscarriage earlier in her earlier pregnancy. So you don't know because they are unattended people. So then you have to send the antibody titer. So if it is more than 1 is to 1 to 1 is to 16, indicates high risk of hemolytic disease of the newborn. Or serial middle cerebral artery Doppler for fetal anemia. Intrauterine transfusion can be done if severe anemia is there. These are things which are possible these days. Or if the fetus is mature enough, then you can attempt early delivery. Now, the questions that can come from this: a 26-year-old second gravida, one primary woman with blood group ORH negative presents at 28 weeks for routine antenatal visit. Her antibody screen indirect Coombs test is negative. Her previous delivery was an RH positive infant and she received appropriate postpartum immunoglobulin. Which of the following is the most appropriate management at this point? She is 28 weeks. They did an indirect Coombs test which sensitizes the presence of antibodies in the mother. So it is negative. No treatment is needed until delivery. Administer 50 microgram intramuscular now. Administer 300 microgram intramuscular now. Administer RHIG only after the delivery of infant is RH positive. Perform the Kleher-Betke test and give additional dose of RHIG based on the result. So anyone who can suggest me an answer here?
So we will go with administration of RH immunoglobulin 300 microgram now.
So at this time, you have to give full dose of RH immunoglobulin because the mother is indirect Coombs test is negative. That means she doesn't even have antibodies in her body. So you don't want subsequent pregnancy to get the same insult. Are you getting me? This is protecting this pregnancy and the subsequent. Let us suppose if she gets pregnant for the third time. So this time around, most likely she doesn't have any antibodies in her, but that doesn't mean that you will not go ahead with the prophylaxis. So you will do your bit. And the RH negative woman, so the answer is giving 300 microgram now, should receive prophylactic RHIG at 28 weeks and within 72 hours postpartum. So 300 microgram, this question can come. 300 microgram protects against 30 ml of fetal whole blood. Exactly correct answer. Now is LO immunization and management of hemolytic disease of the newborn. A 30-year-old G2P1 woman at 28 weeks is R negative. Her antibody screen is positive. So her indirect, that is indirect Coombs test is positive with a titer of 1 is to 64. Her previous child had neonatal jaundice requiring exchange transfusion. Ultrasound shows hydrops fetalis and increased MCA Doppler velocity. That means the fetus has anemia. So, which of the following is the next best step? So, she's just 28 weeks. Already, the fetal uh, already the fetal hemolysis has begun, what we can make out from the situation. So, will giving RHIG now help the patient?
No, sir.
So so LO immunization has already occurred. So that means now it will not help. It has already occurred. The purpose of RH, this NTD, was not to let the exposure happen. Now the exposure has happened. The lady already has antibodies. So if you are going to give more antibodies, it is not going to help. She already has enough. So now administering RHIG at this moment is not advisable, not recommended. It is not going to help. Perform amniocentesis to measure bilirubin levels. This will not help in any way. Arrange for intrauterine transfusion with O negative, antigen negative blood. Absolutely correct. So we see that the MCA Doppler velocity is increased, indicating anemia. So we would arrange for intrauterine fetal transfusion. So we would go for blood transfusion, but with a O negative, antigen negative blood. Giving corticosteroids, planning early delivery is not recommended. No mention of steroids anywhere in the process. So this option is absurd. Repeating antibody titer levels every 4 weeks again is not going to help. So we remember that from our lecture today, 1 is to 16 and above. Here the titer is 1 is to 64. It is a very high titer. So there is no fun of repeating antibody titer every 4 weeks. By that time, the child would have been killed by the mother's antibodies. So the answer is arrange for intrauterine transfusion. So once maternal sensitization has already occurred, RHIG is not useful. High titer, that is more than 1 is to 116, indicates risk of fetal anemia. MCA Doppler, middle cerebral artery Doppler of the fetus, is the preferred non-invasive test. This tells us that anemia is present. So the anemia is present, you should go for a intrauterine blood transfusion. Now is another question from the same topic on Kleehor-Betke test and dose calculation. So another lady, almost 27 years old, at 34 weeks gestation is brought to emergency department after a motor vehicle accident. Her blood type is Rh negative and antibody screen is negative. So she is not exposed. So the Kleehor-Betke test, it reveals 1.2% fetal cells. Maternal volume, blood volume is 5000 ml. So, how many vials of 300 microgram of Rh immunoglobulin should be administered? One vial has 300 micrograms. Two vials would have 600. So, what we see here is that 1.2% fetal cells. So, let us calculate. So, 1.2% of 5000 ml. This will be the equation, right? So 1.2 divided by 100 into 5000. So this is 0, 5 2s are 10, 5 1s are 5 and 1 6. So what we get here is, so 60 ml of fetal blood is there in maternal blood. And as we remember, 300 microgram is sufficient for 30 ml fetal blood. So how many doses we need? We need 600 mcg. So how many vials would be needed?
2.
So one should always think about, uh, going for an extra correction. Why? Because we need to neutralize the fetal cells. Remember prozone phenomena? So that is why I told prozone phenomena. So you will neutralize with 2 vials, and to perform prozone, you need another 1 vial. So the answer would be 3 vials. So 2 will be exactly neutralizing them. Extra 1 vial will be preventing any subsequent exposure that happens during that. Just a second. Anji. Okay, done. So we need one vial covers 30 ml. So we need always round up plus add extra one vial. That is for learning. So that becomes three total vials. How many vials? Three. So why do we need three? Because you remember the diagram. This is the antigen. So you need basically just to cover completely so that the antigen is not available for the sensitization of mother's blood. Is that okay? This is the norm that we follow. Is that okay?
Yes, sir.
All right. So the next important topic is thyroid disorders in pregnancy. These are the topics that we did not cover in the last topic, last class. Just a second. So pregnancy, it induces significant changes in the thyroid physiology. Who alters it? The estrogen and beta HCG. So many times the option is there that progesterone also does that. That is wrong. Progesterone does nothing. It is the estrogen and beta HCG. So estrogen, what does it do? It increases the thyroid binding globulin. That is a protein which is synthesized in the liver. It is stimulated, the liver is stimulated by estrogen to produce more thyroid binding globulin, resulting in higher total T4 and T3 levels, while free T4, T3, they remain normal. Now, this question has come in the exam many times in true and false. That what does estrogen do? It increases the bound T4, T3, but the free T3, T4 levels are essentially normal. Beta HCG, it directly stimulates thyroid, causing slight decrease in TSH. So T3, T4 levels are increased by beta HCG, so TSH can decrease during the first trimester. So that is why trimester specific ranges of TSH are there. In first trimester, it is 0.1 to 2.5, then 0.2 to 3, and third trimester is 0.3 to 3.5. Why so much of hoopla? The hoopla is there, the chaos is there, the shouting is there for thyroid in pregnancy because if the thyroid is inefficient, insufficient in the mother, it is so essential for the fetal well being that the fetal growth, mental growth will be retarded. So, earlier the term used was cretin, CRETIN, that a child born as a hypothyroid is a cretin. Cretins are idiots, means their IQs are low. Their brain development ceased at I don't know what level. So, they do not mature enough in the neurological system. Hypothyroid in pregnancy, the most common cause is Hashimoto's thyroiditis, that is autoimmune. Complications are miscarriage, preeclampsia, low birth weight, and impaired fetal neurodevelopment. So it affects the neurological development. So how do you diagnose the T3, T4? Free T3, T4 will be low and the TSH will be elevated. You don't want the TSH to be more than 3 in any case of pregnancy. I mean, that is 3 is the magic number. So even if you are in the first trimester, second trimester, third trimester, you need to keep it less than 3, the TSH. If it is more, that means the T3, T4 levels uh, are decreased, and this will affect the IQ of the unborn child. So the norm is that levothyroxine dose should be increased by 30 to 50% upon confirmation of pregnancy. Usually these patients are Hashimoto thyroiditis. So if they are taking 100 microgram of dose, then you increase the dose either to 130 or to 150. Because 130 tablet is not available, then you directly go to 150. Maintain the TSH in the lower half of the trimester specific range. That means you need to keep it around 2 to 2.5. Monitor TSH every 4 to 6 weeks during pregnancy. So, how much time does it take for TSH to re-establish? It is 45 days. So, essentially, 4 to 6 weeks is the time. Hyperthyroidism in pregnancy, the common causes are the usual causes like Graves' disease, uh, and autoantibodies, gestational transient thyrotoxicosis because of beta HCG. I told you beta HCG directly stimulates the thyroid to produce T3 and T4 levels. So the diagnosis is increased T3 T4 levels, decreased TSH, and if you are very inquisitive, then you might find T receptor antibodies or TSI antibodies as of Graves' disease. So the treatment is very important that in first trimester, the dose is propyl thiouracil. So in first trimester, you give only propyl thiouracil, that is 9 weeks. So 9 to 12 weeks. So after the first trimester, you have to shift to methimazole, not neomercazole. It is methimazole is a different molecule. Methimazole. So goal is to maintain free T4 in normal range. That is, you do not check T as such, you check T4 levels. So if the T4 levels are normal or in high normal range, that is uh, recommended. What you do not do is never give a pregnant female radioactive iodine for even for Graves' disease. It is contraindicated. Then comes postpartum thyroiditis. Postpartum thyroiditis is an autoimmune disease, thereby destruction of thyroid within 1 year of postpartum. Typically biphasic. Initially, the patient becomes hyperthyroid because of the release of hormones. Then there is hypothyroidism, and then there is recovery. Hyperphase, you give beta blockers for symptoms, tachycardia, palpitations, sweaty palms, anxiety, diarrhea, all the symptomatic responses. In hypophase, definitely you will just replace the thyroxine. Usually self-limited, but after 2 to 5 years it happens. Postpartum thyroiditis is very common. So let's go for the questions. A 30-year-old second gravida woman presents for prenatal care at 8 weeks. That is first trimester. She has history of hypothyroidism, treated with levothyroxine 100 microgram. Her last TSH before conception was 2, but today it is 4.2. So the first trimester range is 0.5 to 2.5, and we need to keep it almost around 2. So what will you do? You increase the dose by
30 to 50%.
30 to 50%. So what is the best next step? Continue same dose and recheck TSH at 20 weeks? Wrong. Stop levothyroxine until delivery? Wrong. Increase the levothyroxine dose by 30% and recheck in 4 weeks? Correct. Add liothyronine? Wrong. No treatment needed as this is normal in pregnancy? Wrong. So the answer is very clear that you increase the dose by 30%. So the answer is correct. Pregnancy increases thyroid hormone requirement due to elevated TBG and metabolic demand. Thyroxine dose should be increased by 30 to 50% immediately. Monitor every 4 to 6 weeks. Untreated hypothyroidism can lead to miscarriage and impaired fetal neurodevelopment. Now, hyperthyroidism question. 26-year-old first gravida at 10 weeks, that is second trimester. Palpitation, weight loss, heat intolerance. Examination shows diffuse goiter, mild proptosis, so possibly Graves' disease. TSH is less than 0.01, free T4 is elevated. She is diagnosed with Graves' disease. Which of the following is best management? Start methimazole immediately. Start propyl thiouracil now. Switch to methimazole after first trimester. Start levothyroxine replacement. Radioactive ablation. Observe without treatment. So observing without treatment is not the answer. Radioactive iodine ablation is contraindicated. Starting levothyroxine replacement, the patient is already high on levothyroxine, so we will not give it. Now, starting methimazole immediately and starting propyl thiouracil only is based on what is the examiner thinking about the 10th week. So, basically, he has suggested that switch to methimazole after first trimester. That means they are considering 10 weeks in the first trimester only. So 12 weeks से पहले है. So it is first trimester only. So what will you do is you'll start with propyl thiouracil, then switch to methimazole. So the answer is starting propyl thiouracil now and then switching. So PTU is preferred in the first trimester to avoid methimazole embryopathy, that is aplasia cutis, choanal esophageal atresia. After 16 weeks, switch to methimazole to avoid PTU-induced hepatotoxicity. So both of them, they have their own issues, but methimazole embryopathy occurs in the first trimester, so you don't give it. Later on, you don't give propyl thiouracil because it can cause liver damage. So what is tested? Free T4 levels are tested. Postpartum thyroiditis. A 29-year-old woman presents 5 months after delivery with palpitations and anxiety. So this is phase 1 of postpartum thyroiditis, where there is excessive release of the hormone. So exam shows mild tremor and no eye signs. TSH is suppressed. T4 is elevated. RAI uptake shows low uptake. 6 months later, she develops fatigue and weight gain with elevated TSH. What is the diagnosis? Graves' disease. So in Graves' disease, TSH will never be elevated. Subacute decurvan. Decurvan is very painful. So patient has not complained of painful. Postpartum thyroiditis, biphasic, correct. This is most like possibility. Hashimoto's thyroiditis is hypothyroidism. Factitious thyrotoxicosis, this is not a case of thyrotoxicosis. This is a biphasic picture that they have given. So that is also not the answer. Postpartum thyroiditis fits the situation. So occurs within 1 year postpartum due to autoimmune inflammation. The pattern is hypothyroid, and recovery sequence. So radioiodine uptake differentiates it from Graves. In Graves, the RAI is increased. However, in postpartum thyroiditis, RAI is decreased, radioactive iodine uptake. So this is the chart for you. You can take a snapshot of this. So this is in pregnancy. So Hashimoto's, Graves' disease, gestational thyrotoxicosis. So you need to remember that in gestational transient thyrotoxicosis and postpartum thyroiditis, the RAI uptake is decreased, not increased. So Graves' disease, it is increased. So you can see that even if you have seen the patient in transient thyrotoxicosis or postpartum thyroiditis, where the hyperthyroid phase is there, still you can differentiate it from Graves' disease by decreased radioactive iodine uptake. Just a second. हेलो जी 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 मैं कर लेता हूँ करा ठीक है बेटे ले लो हाँ जी थैंक यू जी थैंक यू सो मच Next is very important topic, that is differentiating between acute fatty liver of pregnancy and HELP syndrome. Now this question, it boggles us in the examination because they look so much alike. Both acute fatty liver of pregnancy and HELP syndrome, they are serious, very life-threatening liver disorders of pregnancy, and they typically present in the third trimester. Because they have overlapping features but differ in their pathophysiology, their biochemical profile, and also how you will manage these patients, they are different. That is why the correct differentiation is very crucial, not only in the MCQ but in practical life also. So you have to understand what the patient is going through. Not every AFLP is preeclampsia, not every preeclampsia is AFLP. So you will have to decide by the presentation and biochemical profile. Now let us see. So we've just, because this is an examination oriented lecture, so we have just ventured directly into the differentiation. So AFLP, what is happening is there is microvascular fatty infiltration. So basically fatty liver like in everybody else, but in pregnancy it is like exponentially fast. It causes so much of inflammation that liver swells up very fast. Liver swells up so fast that there is so much of pain and so much of damage to the liver that it leads to literally fatal outcome. Microvascular fatty infiltration of hepatocyte due to mitochondrial fatty acid oxidation defect, that is LCHAD deficiency in fetus often implicated. Whereas in HELP syndrome, it is diffuse endothelial dysfunction and DIC, regional DIC like picture, microangiopathic hemolysis secondary to severe preeclampsia leading to liver dysfunction. So just like in dengue fever, in dengue fever also there is thrombocytopenia and regional DIC. So there is liver dysfunction in dengue also. But AFLP is direct hepatocytic damage. So typical onset is third trimester for both, usually after 30 weeks, but HELP syndrome is usually seen in females with preeclampsia, eclampsia. Clinical features are malaise, nausea, vomiting, right upper quadrant pain, epigastric pain, jaundice, very fast encephalopathy, hypoglycemia because of liver failure, and of course DIC. Whereas in HELP syndrome, there is pain, nausea, vomiting, everything, but there is hypertension, there is proteinuria, and there is increased uric acid levels also. So jaundice is mild, whereas in acute fatty liver of pregnancy, jaundice is robust, very robust. So, blood pressure usually normal or mildly elevated. In HELP syndrome, it is markedly elevated. Patient may develop seizure because of preeclampsia or eclampsia, but in AFLP, if the seizure has happened, that is due to hepatic encephalopathy. Lab findings: hypoglycemia, marked elevation in bilirubin, AST more than ALT, prolonged INR, increased ammonia, increased creatinine, liver dysfunction with kidney dysfunction with leukocytosis. However, in HELP syndrome, there is a hemolysis. LDH is elevated, schistocytes are there, AST, ALT are increased, but more than 1,000, like in dengue fever. So I always say that dengue fever presents almost like, uh, you know, this HELP syndrome. And there is thrombocytopenia. The bilirubin elevation is mild, whereas it is elevated in AFLP. Urinalysis, no proteinuria or mild, but in HELP syndrome, significant proteinuria. Ultrasound, bright echogenic liver due to fatty deposits, whereas in HELP syndrome, it is normal. In management, immediate delivery and maternal stabilization with glucose infusions, correction of coagulopathy support a very intense management. Whereas in HELP syndrome, immediate delivery, maternal stabilization, giving magnesium sulfate and correcting the blood pressure. Maternal complication, DIC, hypoglycemia, renal failure, liver failure, brain failure, that is encephalopathy. In HELP syndrome, DIC, placental abruption, liver rupture, renal failure because of ischemic injury, DIC injury. Fetal outcome, high perinatal mortality in HELP syndrome, improves with early recognition, whereas in HELP syndrome, if you deliver the baby, everybody is safe. Doctor, patient, and the child. Clinical pearls to remember is that AFLP often has severe hypoglycemia and coagulopathy mentioned in the question paper out of proportion to liver enzyme, that is less than 1,000. This is key differentiator. HELP syndrome is commonly associated with hypertension and proteinuria, preeclampsia, eclampsia, seizure also. Both require urgent delivery, but AFLP often needs intensive critical care. Glucose infusion, plasma exchange, so much so. Liver biopsy is not needed and is contraindicated due to coagulopathy in both the diseases. So let's see the questions. At 29-year second gravida, 36-week pregnant with malaise, vomiting, yellow discoloration, BP normal. Lab show AST 350, ALT 310, bilirubin 7.2, out of proportion elevated. Glucose only 38, hypoglycemia. PTINR 2.1, platelet almost more than a lakh, 1 lakh 30. Urine dipstick negative. What is the diagnosis?
Acute fatty liver of pregnancy.
So, how will you proceed? She is 36 weeks. So, you will go for glucose infusion, delivery of the fetus, and correcting coagulopathy. So plan should be very clear that glucose infusion plus delivery have to be done subsequent. I mean, collect together, and intensive care. No BP control is required. Nothing else. So answer is AFLP. So combination of hypoglycemia, prolonged INR, hyperbilirubinemia, absence of hypertension or proteinuria favors AFLP over HELP. Viral hepatitis may also cause jaundice and transaminitis, but AFLP shows coagulopathy and hypoglycemia in peripartum period. A 32-year-old woman at 35 weeks presents with right upper quadrant pain, nausea, headache. BP is 168 by 110, urine dipstick 3 plus protein, AST 1200, LDH 980, platelet 70,000, bilirubin modest 1.5, glucose modest 95. So, what is the diagnosis?
HELP syndrome.
This is HELP syndrome. So the triad of hemolysis, increased LDH, elevated liver enzymes, and low platelets is hypertension with proteinuria, HELP syndrome. Immediate delivery, stabilization with magnesium sulfate and blood pressure control is indicated. Unlike AFLP, hypoglycemia is absent and coagulopathy is milder. So, how do you manage? You stabilize the mother, manage the airway, hemodynamics, then manage the glucose, correct the coagulation, then go for delivery, regardless of gestational age in both the conditions once the diagnosis is made. AFLP specific IV glucose, FFP, or cryo, correction of metabolic derangement, and delivery. In HELP syndrome, control the blood pressure, give magnesium sulfate. Steroids, controversial, but you can give because they help in some seizure control also. Postpartum monitoring, liver and renal function usually improve within days after delivery, but can be bothersome in AFLP because the injury is grave, injury is severe. So that brings us to the end of the today's class. These were the points which we had missed in the last class. We had covered the diabetes in pregnancy and all other topics in the previous class. So if there are any questions, you can leave them with Sana and we will take them. Okay.
How to differentiate bud cherry from other liver diseases?
Say again.
How to differentiate bud cherry from other liver diseases in pregnancy?
Bud cherry.
Yes, sir.
So basically, why would bud cherry happen in pregnancy? Because one can say that it is just like increased coagulopathy stage. Pregnancy is increased pregnancy state or increased what you say. It's a procoagulant situation. So what happens is that because of the venous flow obstruction, this will happen. Now the problem is that it is very sudden in onset. So sudden in onset that patient will say that I was fine. It is just like DVT. It is just like deep venous thrombosis. So whereas in other viral hepatitis or other conditions, it usually takes time and there will be a history of fever and other things like loss of appetite and all, but there is sudden onset pain and ascites in case of budd chiari syndrome. In what specific respect do you want to know, from viral hepatitis or other diseases?
So actually, I want to know what are the presentation of the patient and how you diagnose bud cherry.
Okay, so basically, Budd Chiari, you have to understand, as I told you, that there is this problem of, coagulopathy, which leads to increased blood clotting in case of pregnancy. So pregnancy is considered as a procoagulant state. That is why DVT happens.
Yes.
So there is hepatic congestion, hepatomegaly, severe ascites, and very fast dysfunction. Now, this hypercoagulable state is because of increased fibrinogen, increased coagulation factors, and decreased protein S. So, the women who have an underlying condition like thrombophilia, they are at a higher risk. Now, the clinical presentation is usually very acute. Very less patients may come with subacute or gradual presentation, but usually they come in acute onset. Matlab, they will be absolutely okay a few days back and now they are totally in problem. The major problem is pain abdomen because it is a thrombus in the portal vein. So it is literally in the IVC and portal vein. So it is literally an acute condition, just like DVT. There is a lot of pain, and then there is onset of ascites very fast. So one, she's pregnant, but the abdomen will increase to tightness. So the volume will increase very fast. So the patient may have jaundice and splenomegaly, but it is very difficult to differentiate splenomegaly in these patients. But jaundice, of course, you can see. The LFTs are mild to moderately elevated, means below thousands. The Doppler ultrasonography is the first line of defense how you manage these patients. So there will be absent or reversed hepatic venous blood flow, and you can usually see the thrombus there. Coagulation profile, will be either, usually it will be normal or procoagulant side. So how do you manage? Immediately you manage like cirrhosis decompensated, like salt restriction you would do. You will not use diuretics, avoid dehydration, correct the coagulopathy if at all. So you will start the enoxaparin in these patients. However, in AFLP or uh, HELP syndrome, the anticoagulants are never used. But in case of Budd-Chiari, you will use anticoagulants, that is enoxaparin. So definitive therapy would always remain tips or something like that, so that you can decompress the portal system. The problem is the portal system. Now, because of these techniques and all, you can save these patients. But important is, if somebody, some female has developed Budd-Chiari syndrome towards the end of the pregnancy, you will need to continue anticoagulation later on also, because of course this is a DVT like situation. So Budd-Chiari is basically a DVT in the hepatic system. So that is how it presents: pain, swelling, and ascites. But it usually will be acute in onset, less possibility of gradual onset. And yes, coagulopathy will not be there much. In fact, you will need to give Clexane or low molecular weight heparin.
Okay,
Is that
thank you,
clear?
sir. Yes, sir. Yes. Thank you, sir.
Okay. Bye bye, students.